Okay, everyone. Thank you so much for joining us. All 477, wow, of you so far. Thank you so much. I hand you over to wonderful hands. The most wonderful person is going to be our moderator for this evening, and we thank her so much for taking the charge to lead us through this wonderful event. I hand you over to Dr. Arnold Brown Morgan.
Good evening, everyone. Good evening, Sam. Sorry for a little bit of delay. It happens as a doctor occasionally. My apologies. This is a wonderful evening for a wonderful webinar on some really relevant topics. And I would like to welcome all of you here this evening as we try to explore the whole field of vaccination in the elderly, nutrition, and ethics. And I'd like for us to just go ahead quickly and open with a word of prayer from Dr. Arlene Henry Dawkins, an executive board member of the CCFP Jamaica. Dr. Dawkins, over to you.
Good evening, everyone. May we welcome the presence of Almighty God, Jesus Christ, and the Holy Spirit as we bow our heads in prayer. Our loving, awesome Father in heaven, we thank you for this opportunity to again share relevant and useful information through this virtual seminar hosted by the Caribbean College of Family Physicians of Jamaica. We pray that the Holy Spirit will hover in our midst and expertly guide and lead all the proceedings tonight. May He grant wisdom to all the presenters as they brilliantly share their knowledge on the important topic of vaccination and the elderly, with particular focus on the ethical considerations in this special group of persons. May our thoughts and discussions be inspired by you as we eagerly receive all the valuable information by the presenters. Grant that as we learn, we will capably utilize the knowledge gained to enhance the quality of life for this vulnerable elderly patients in our care. May you richly bless the moderators, the sponsors of this seminar, the administrator, and the audiovisual personnel as they perform their roles tonight to ensure a smooth and flawless flow of the proceedings and an excellent seminar. All these we humbly ask through your precious Son, our Lord Jesus Christ. Amen.
Okay, everyone. Thank you, Dr. Henry Dawkins, for that wonderful start to our evening. I would like at this time to welcome our beloved president of the CCFB, Dr. Seni Onanuju, for a word of greeting and welcome. Dr. Seni, over to you.
Good evening, everyone. Specially invited guests, Professor Denise Eldemire-Shearer, Doctors Laura Naranjo, Joy Callender, Peter Glegg, and Attorney at Law, Chukwuemeka Cameron, Moderator Dr. Anna Brown Morgan, esteemed colleagues, staff of GSK, staff of INDUS Pharma, IT support personnel, Mr. Samuel Heron, the CCFP Secretariat, headed by Ms. Lynn Thompson-Hyatt. Friends, ladies and gentlemen, a pleasant good evening to you all. It is indeed my pleasure and honor on behalf of this Caribbean College of Family Physicians Jamaican chapter to bring you greetings and welcome you to this evening's webinar, main focus, vaccination, nutrition, and ethics in our adult and elderly population. As such, we have a mixture of topics ranging from vaccination in our adult and older adult population, nutrition in the elderly, and the medical, legal, and ethical issues surrounding these challenges that are quite topical at this time when much emphasis is being placed on COVID-19 vaccination, as COVID-19 is being recognized as an ongoing pandemic. Historically, the drive to vaccinate is usually greatest in our childhood population. As people grow older, less attention and importance is given to vaccination. However, as the population ages, chronic diseases such as COPD, chronic renal failure, hypertension, diabetes, and even malignancies increase in prevalence. Some of these chronic diseases, along with their comorbidities, may also need some vaccines to reduce their frequency and intensity of exacerbation. It is important that as we embark on any form of vaccinations, especially in our adult and older adult and elderly population, we are guided by recommendations that are evidence-based. It has often been said that we should let our food be our medicine and our medicine be our food. Finding the right balance between nutrition and health has been an ongoing challenge throughout the ages. The concept of proper holistic nutrition becomes ever more important and significant as our population ages. Today, we embark on confronting some of these nutritional challenges in a holistic manner as we seek to find that synergism between nutrition, health, and aging. The practice of medicine is guided by ethical codes, which essentially state that a doctor should do no harm in the management of his or her patient. A part of the Hippocratic oath that doctors take states, I will give no deadly medicine to anyone if asked, nor suggest any such counsel. Essentially, do no harm. It is with these core values in mind that we consider the issues to be discussed during this evening's webinar. It is also for these reasons that the CCFP thought it fit to focus on our elderly and often neglected and under-recognized group within our population. The college is proud to partner with companies and entities that share similar core values, such as GSK and INDUS Pharma, who are our proud sponsors of this evening's webinar. As such, we have a lineup of dynamic and exceptional speakers who bring a vast wealth of knowledge, wisdom, and experience in their respective disciplines to us. Professor Denise Eldemire-Shearer, Doctors Laura Naranjo, Joy Callender, Peter Glegg, and Attorney at Law, Chukwuemeka Cameron. We welcome them all. We also welcome, I feel confident that we will certainly be well enriched, informed, and enriched by their presentation. A special welcome to our members to whom we are immensely grateful for their continued support despite many challenges. On behalf of the college, I thank and welcome you all, and I invite you to sit back and enjoy the presentations. Thank you, and God's richest blessings.
Thank you, Dr. Sene Onanuju, President of the Caribbean College of Family Physicians, Jamaica Chapter. It is for me now to welcome to our podium Dr. Laura Teresa Naranjo Lara, who is a representative doctor from GlaxoSmithKline. She graduated from the Central University of Venezuela, and welcome, Dr. Naranjo. She's a graduate from the University Central Venezuela, and she proceeded to specialize in pediatrics with a subspecialty in pediatric infectious diseases. She trained in infectious diseases in the immunocompromised hosts. And she did this at St. Jude's Research Hospital in Memphis, Tennessee. And she then advanced to another course at university, tropical medicine in Peru. She's a professor and in infectious diseases in the Tropical Medicine Institute, Central University of Venezuela. And she is also working, or has also worked with the Medical Institute, is it Carlos III, Madrid in Spain, a medical institute, where she also worked. But she has been the coordinator and medical consultant for the HIV program in tropical medicine, in the Tropical Medicine Institute, Central University of Venezuela until 2010. She also was the infectious diseases specialist for liver transplantation program at the Metropolitan Polyclinic of Caracas until 2010. So she's also co-authored several textbooks, medical textbooks, wonderful. And let me tell you that what happened in 2010 is that she moved on to a position with GlaxoSmithKline, where she is the medical affairs manager in vaccines since 2010. And she's also a national investigator in the National Investigator System in Panama. Now, I would love for her to tell us a little bit about what that is. But I'd like to use this opportunity to welcome Dr. Naranjo to the stage, and she is going to deal with us, talk to us, and make sure that we know everything that we need to know about the vaccination in adults and older adults, and why the evidence for giving these older adults vaccination and recommendations as to how to go about the process. So Dr. Laura Naranjo, it's over to you. Welcome, and please go ahead.
Thanks a lot for this presentation. But you mean that I am your friend. So thanks for being here to share our knowledge regarding adult vaccination. And I will be focusing in a specific disease as a pertussis prevention. So I will share my screen. Okay, so let's see.
Display settings at the top beside that. Next one, right beside it to the right.
Yes, but I have the
Presenter view, right. If you click on display settings, it should change.
Yes, let's check.
No, let me help you here. All right, no problem. So let's click on share screen. At the top where you see basic and advanced, click on advanced.
Okay.
And then you'll see portion of screen. There's a little box with a plus sign. All right, that little box, just put it right where you need and you're good. Actually, we're seeing it perfect now.
Okay, perfect.
Yep, perfect.
Okay. Well, yes, we will talk about pertussis prevention. And this is a really good topic to think in adults and older adults, because sometimes we think about pertussis in children, but I will tell you why you have to think more about pertussis in adults. So this is my agenda, and I would like to start telling you that in the early 90s, the society had a relatively high proportion of children, and a life expectancy was around 52 to 55 years old. But this is in evolution during the years, because now we have a more proportion of older adults, and the life expectancy is about 80 years. So this is important because we need to work with those people and with this population, because they need healthcare, they need advice regarding nutrition, regarding vaccination, regarding all the disease that the older could have. But the other thing that I would like to share with you is the immunosensor. And this is a term that describes the natural age-related decline in immunity that occurs in older adults. This is the decline of the immunity, the response of the immunity against some pathogen that those people could have. And what happened here? The problem is the dendritic cells are, declining, fewer circulating of this kind of cells, and is important because these cells detect and engulf pathogens and act as a messengers between the innate and adaptive immune system. But if you don't have this stimulation from the dendritic cells, you won't have enough T cells, enough B cells, and of course, less production of antibodies. So this is important to know, because you have to do something. You have to protect those older adults in terms of have some tools to prevent disease, and one of those tools are vaccines. So as I mentioned before, I will focus on pertussis disease, and I would like to tell you that I say that pertussis is an underreported and underrecognized disease, because we usually remember pertussis in children, because the clinical symptoms of pertussis in children is classic. When a child has a pertussis, because the child is very bad. The child can die because of pertussis. But in adults, it's different, the clinical presentation. Sometimes they have atypical and non-specific symptoms that can be a difference in terms of the differential diagnosis that we have to think in those persons that the main symptom is cough. And I would like to show you some of the clinical features in adults when they have pertussis. And as I mentioned, cough is the main symptom, and all people that have a symptomatic pertussis have cough. But this cough could last at least 3 weeks or more. This is the patient that have cough, and can't sleep, and can't go to the work, and can't do the daily routine activities, because the cough doesn't permit the daily activities, and they feel very bad. And also they can have this classic group, but is less than 50% of the patient could present that. The other thing that is important to mention, that these people who have pertussis, symptomatic pertussis, can vomit, have vomiting after the cough, sometimes apnea, sometimes rib fracture, and it's important to think in this patient that comes to you for your care, think that this could be pertussis. And the other thing is that sometimes the diagnosis tests are difficult to be available, because sometimes, or the best test is the culture, but sometimes they have a lot of specific things to make a good culture and have the pathogen in the culture. This is high specific, have high specificity, but a low sensitivity. Other tests are PCR and serology, but sometimes in the time that the adults seek medical care, the time window for culture and PCR have passed, because these two have to be performed in the first stage of the disease. But when the patient comes with you, probably it's late to get the pathogen. And the other thing that is important to highlight is the estimated numbers of pertussis sometimes is less than reported. Because as you see here, probably the report of cases is very low, but we know that there could be more than 78 times of this number. And this is because pertussis is a high contagious disease, and we will review this later. And in this slide, I want to mention that first we saw the disease in children, but during the time, this epidemiology has changed to have more cases in the older age, and the reason for that is that probably children that were vaccinated, they lost the immunity, and they or in older age they can have the disease because the immunity was lost. And here I would like to share with you this impressive comparison between pertussis and measles. As you know, measles is one of the most contagious disease described in the medical literature, and pertussis is as contagious as measles. So one case of pertussis can have at least 10 to 15 secondary cases. And the problem is that this is exponential. because these extra cases contagious around 10 to 15 more. So this is important because sometimes we don't recognize the disease, we don't diagnose the disease, and we don't report the disease. So this is the reason, because we don't have enough numbers in medical statistics regarding this disease. But when you compare pertussis disease with COVID, for example, that with Delta, for example, one primary case can have 3 secondary cases. But when we had Omicron, the number was more than 3, was around 10 to 7 cases. So this is important because you have to think in pertussis as a respiratory disease, and you have to diagnose this disease, think in this disease, and prevent this disease. And I just want to highlight some characteristic of the pertussis, because when you see in this part of the graph, the children that get vaccines, 3 vaccines in the primary vaccination, the antibodies is high, then they decline some before the booster vaccination, and then they increase again. But these children are protected with diphtheria, tetanus, and pertussis, because they receive their pentavalent or hexavalent vaccines. But the problem is that if you don't offer a booster for those diseases, probably you won't have enough immunity during the life, and the problem is that you can have the disease, or you can have Bordetella pertussis as a reservoir. So it could be a risk of transmission from this population to those children that have incomplete schedules, or those children that their mother didn't get vaccines, and then this newborn is vulnerable to the disease because it's so young to get vaccine until 2 months of age. So the importance of this graph is that highlight that you have to have enough antibodies to protect against the disease. But if you have a declining of immunity, you won't have the protection. So you need a booster of those 3 diseases every 10 years to be protected against pertussis, diphtheria, and tetanus. So probably you always remember tetanus, and when you go to the emergency room, the first question is if you got vaccines regarding tetanus. And the second question is when did you get the vaccine? So, so you know that every 10 years you have to get vaccines against tetanus. So please remember that we have vaccines, combined vaccines that include tetanus, diphtheria, and pertussis, and then you can be protected against those 3 diseases. So pertussis in other adults is with us. If you see this 3 chart, you see that the comparison between 1993 to 2005, the percentage of pertussis cases in children less than 18 years decreased during the time. But when you see what happened with adults more than 18 years to 64 years, the cases start increase, and and also in those adults more than 65 years. So it's important because the vaccination in this group of children decline the disease, or we don't have many cases of pertussis, but this population lost their antibodies, and then they have to have a risk to get disease, pertussis disease. And also, we have here the difference between age. The important thing is the pertussis incidence is similar across age categories, but when you see the hospitalization related to pertussis disease, you see that the hospitalization are 4 to 6 times more likely in older adults more than 65 years. So please remember that pertussis exists, and you have to be prepared and protect those patients that you usually give the health care for them. The other point that I want to mention here is the quality of life. I told you a little bit before, but if you compare the quality of life with influenza, for example, you know that influenza is an acute disease. So if the patient won't complicate, the influenza lasts around 3 to 5 days. But the problem with pertussis, that is a subacute disease, because the pertussis disease can last more than 3-5 months, and the quality of life of this patient is very bad. The other interesting thing to think in pertussis disease is that you can have an outbreak in nursing home. So if, as I mentioned, you know that the disease is highly contagious. So if you have in those two studies, you have 2 confirmed cases in staff and 2 suspected cases in residents, but the transmission results in 7% of residents and 17% of staff. It means that those index case contagious this resident and also staff, because the staff didn't get vaccine. And the other study showed that these members working across 3 retirement homes, and they got the disease, and then this result in a transmission of 50% of residents and 17% of staff. So it's important that you think that this is highly contagious disease, and you have to be protected against the disease. So what happens with those patients that have chronic respiratory disease as asthma or COPD? Well, I would like to share with you this study that show us that 87% of adults hospitalized with pertussis had at least one condition, one comorbidity. And as you see the chart, you see that 87% had more than one condition, but see the condition that's are really a frequent condition in this kind of population. So obesity, smoking, asthma, diabetes, COPD, cardiac condition, renal disease. So it's important that you know that there are more risk in those older patients, that not only the age, but also the chronic disease can have increased risk of severe pertussis. And this is a data that tell us that COPD can have more than doubles of the risk of pertussis. And this means that increase the hospitalization, increase the cost, and increase the burden of the disease. And also, we have the numbers for asthma patients that the increased risk of pertussis is around 1.6 and 4 times higher. And this is important because sometimes those older patients have also a chronic respiratory disease. And of course, we have to know that cost, it's important. So those patients that have pertussis plus asthma or pertussis plus COPD cost more than a patient with pertussis only, for example. And we have to imagine that we have to protect those kind of patients from this disease that affect their quality of life, that affect the capacity or the availability to go to the work, to the university, and also the cost is an important thing. But what about vaccination? Well, CDC in the probably 5 to 6 years ago, they already said that patients with the chronic infection, chronic respiratory disease have a risk for infection. And they recommend that those patients had or get the influenza vaccines, pneumococcal vaccine, but also TDAP vaccine, tetanus, diphtheria, and pertussis. And this is important because sometimes we only think that influenza vaccines or pneumococcal vaccines are important for older people. But you have to think that also pertussis, as I mentioned, is important for prevention in this kind of patients. So, and now, of course, COVID-19 vaccine is necessary for this kind of patients. So please, my main message here is that you have to prevent this kind of patient against influenza, pneumococcal, also pertussis, because they have a high risk to have pertussis and complication, hospitalization, and also they could die for this disease. But the other important thing is the update that last year GOLD guidelines had. GOLD guideline is the guideline for the management for COPD patients. And it's important because now they include TDAP vaccination in those kind of patients. So, and what were the reasons for adopting this recommendation? Well, they said in the guideline that pertussis can lead to complications such as pneumonia, as well as exacerbation in patients with COPD. The burden of pertussis is underestimated in older adults, and vaccination is therefore underutilized. A pertussis booster was found to be immunogenic, cost-effective, and well-tolerated. And other thing that we have to be aware is that pertussis vaccine can lower the disease burden and prevent transmission in more vulnerable populations, but not only in the patient, but also in their family, in their co-workers, because as I mentioned, this is a highly contagious disease. So please, I hope that with this talk, you can think about pertussis and prevent against this disease. But I would like to tell something about our vaccine, that is Boostrix, that have enough data to support the vaccination in this kind of population. We have data regarding the immunogenicity with our vaccine in adults and older adults. And also we have data regarding the repeat dose administered 10 years after the first dose. As I mentioned, you have to revaccinate this patient every 10 years, as we do with tetanus. The other important thing is the safety, is the tolerability of this vaccine. We have enough data that report that there is no safety concern regarding the vaccination in this population with Boostrix vaccine. And the other thing is that we have data that support that show us the effectiveness of this pertussis vaccine in this population, and is near to 52%. So we have data. We need to think in vaccinate this population. But also, I would like to highlight that we as healthcare providers, we need to be vaccinated also, because we can be a source of the disease, and we can get the disease. So if you recommend the vaccine, you have to be vaccinated, to give the confidence to your patients. And this is my last point here, because the role of the healthcare provider is essential, because we have a poor uptake in terms of TDAP vaccination around the world. If you see this data, Europe, USA, and Australia have less than 50% of coverage in this kind of vaccines in adults. So we have to do more. We have to do something to prevent the disease. And there is, or there are a lot of studies that already mentioned the importance of the recommendation from the healthcare providers to their patients, because this is the goal to recommend, and probably the patient will accept the vaccination. But if you don't recommend the vaccine, the patient probably don't know that they need the vaccines, and it's important that you recommend all the vaccine that they need regarding the age and regarding their benefits or of well-being. So it's important that you think in pertussis, protect against pertussis. And I like to finish telling you that pertussis is under-recognized in adults. Pertussis is in other adults, and those with asthma or COPD can lead to increased disease burden and healthcare utilization. Although TDAP vaccination helps prevent pertussis, coverage is low, and at-risk groups remain vulnerable to disease. HCPs, or healthcare providers, are key in helping to improve coverage rate in those most at risk of pertussis and its complications, and of course, reducing the vulnerability gap. But asthma and COPD patients are at higher risk for pertussis infection, which way worsen their condition. So you have to vaccinate and use this kind of safety vaccines to protect they again this disease that as I explained before, the disease is with us, and you have to think, you have to diagnose, and you have to report, because we have pertussis around the world. So thank you very much, and I hope you have many questions for me.
Well, I'd like to thank you so much, Dr. Naranjo. Let me say to you that this has been quite an eye-opener, because it is absolutely, this has never, to think pertussis in the adult has never, ever really, no. So this is a real eye-opener, and the extent to which it causes morbidity and even mortality in the adult population is a really a treasure that you presented to us this evening. I'd like to tell you that in the island of Jamaica, you are preaching to the converted. Because of school requirements here in Jamaica, over 90% of our population is vaccinated with the DPT, the OPV, the whole shebang. So we have high vaccination. It's just the COVID now, actually, that had with the vaccination, anti-vax thing that's interfered a bit with us, but we have been so good. So GPs, adult vaccination with DPT, every 10 years, so 50 and age 60 and age 70. That is your message, and look for it. When people come in with these upper respiratory, lower respiratory, rough sounding illnesses, infections, look for it, test for it. And we mentioned the various efficacies of the culture versus the PCR versus the post-infection antibody test. So we thank you. We have been richly rewarded, and we've learned a lot. Thank you, Dr. Naranjo. And at this time, I'd like us to proceed to the GSK video, which will complement Dr. Naranjo's discussion tonight.
Thank you very much.
Right, and we now proceed to our first Q&A. I'm going to ask Sam to be to present the questions, and let's direct them to Dr. Naranjo.
All right, thank you very much. So the first question is, what is the best treatment for this disease? What is the differential diagnosis?
Wow, this is a really good question because, well, the best treatment is macrolide. This is the treatment of the first line of treatment. And the differential diagnosis is many disease, because we think when we have a patient with cough, a lot of things which is mycoplasma, chlamydia, the patient is a smoker, have COPD. Well, the list is very large, but the important thing is in the list, you have to think in pertussis disease. So this is my answer.
All right, thank you very much. So then our next question, how to diagnose pertussis in older adults if symptoms are non-specific? This is from Dr. Doda Reddy.
Yes, it depends of the stage of the disease. As you know, the pertussis disease have 3 stages. There is catarrhal, paroxystic, and the convalescence. If you have the first 2 weeks of the disease, probably culture and PCR is the best test to do. But if the patient come late, probably ELISA have a better, it's a better test for in that stage. But the problem is it's not easy to culture the Bordetella pertussis, and sometimes PCR is the the best test to do. The problem is the cost, the availability of the PCR, and you have to be aware if in the list of the PCR pathogen is Bordetella pertussis, but because sometimes it's not there, because in the laboratory and the physician don't think that they need to have Bordetella pertussis in the list of the PCR testing.
Thank you very much. Dr. Samuels asks, what are the specific recommendations and considerations for the use of Tdap in patients with chronic kidney disease and dialysis dependent?
Yes, this vaccine is indicated for those kind of patients because it's a inactivate vaccine, so it's safe for use in those patients, and it's necessary to protect those chronic patients, regardless the condition. It means that it doesn't matter this is a chronic renal disease or this is a respiratory chronic disease. You have to protect those patients every 10 years to have enough antibodies and protect against the disease.
Thank you so much. And the last one I'm seeing now is from Dr. Murdoch. Do adults who have contracted pertussis in childhood still need to be vaccinated as older adults?
Wow, this is a really good question, because some disease have a protection during all the life, as a measles, as a varicella, But with pertussis disease, even you have antibodies because you suffer the disease, the antibodies will decline with the time. So even you have vaccination or you got the disease, you need to be vaccinated every 10 years because the antibodies in both situations will decline during the time.
All right, thank you so much. That's it for the Q&A. I hand back over to you, Dr. Brown Morgan. But again, we'll have the GSK video played one more time. And thank you very much.
Thank you.
You're going to play it now, Sam?
Sure, I'll play it now.
Okay. Dr. Naranjo, it is just for me to thank you again for your presentation, and which was absolutely needed. It's incredible because it's something I'm sure most of us have not thought of. So thank you again. And thanks GSK for allowing you to come and be here with us tonight.
Thank you, Dr. Brown. I'm really happy to participate in this kind of event, in this kind of webinar with a lot of people that I think you will have a really, really good night today. So
thank you. Yes.
Bye-bye.
You're welcome. And now it is for me to welcome Dr. Joy Callender to join us. And Dr. Callender, please come to us, come to the podium. Dr. Callender. Well, Dr. Joy Callender is just someone who almost does not need introduction because she is such a friend to us over the years. She's been such a good friend to us. But she is a nutritionist and she is a lecturer. And she received her PhD in nutrition from the University of the West Indies, where she was located at the Tropical Medical Research Unit on the Mona campus, where she did her work. Her postdoctoral work includes training in diabetes education in Florida, nutrition policies and programs in Chile, and clinical nutrition for the oncology patient in Florida. Of note, she is a weight management coach. So you notice our Dr. Joy is extremely well credentialed. She presently owns and manages the Nutrition Center in Kingston, in Jamaica, which provides nutrition consultations and offers a range of services, including seminars and webinars virtually. She, as I said before, is a registered nutritionist and a member of the Jamaica Association of Professionals in Nutrition and Dietetics. And she's the first vice president of the Caribbean Obesity Society and the author of several peer-reviewed journals. She's an advocate for Jamaicans adopting healthy lifestyles, and she does online nutritional consultations. So by the telemedicine platform. So I'm just putting in that little plug. We are so much in need of this for our patients, and Dr. Joy Callender can be with them in their homes at their leisure. So Dr. Joy Callender, please let me welcome you now to this our podium, and she is going to speak with us about holistic nutrition for the elderly. So we're trying to focus on the needs of the elderly, and here we will talk about the nutritional needs. So over to you, Dr. Joy Callender.
Thank you very much, Dr. Brown Morgan. It's indeed a pleasure for me to be here. Let me just... Is everyone seeing?
Yes, we are. Perfectly so. Thank you.
Okay, thank you too. So, nutrition for the elderly. And we're suggesting that a holistic approach might perhaps be the best way to deal with the elderly. Our basic goal then, I mean, if you're classified as being elderly, so longevity, but we don't just want people to live longer, we want them to have a good quality of life. In other words, we want them to live a long life experiencing good health. What are some of the issues as it relates to the elderly? Speaking generally now, cognitive decline and memory loss, various dementias, the chronic nutrition-related diseases, malnutrition. I put a little bit in there on happiness. We'll see where that takes us. Healthy eating, that's the nutrition. And it's always impossible to talk about nutrition without speaking about exercise and physical activity. Now, we just listened to Dr. Narangha talking about the reduced efficiency of the immune system as you get older. There's an age-related decline in immunity. So that's a major issue. I already mentioned the nutrition-related chronic diseases, polypharmacy. As persons get older, they tend to be diagnosed with more and more diseases and conditions, and to be prescribed all sorts of different medications for each of those conditions. And sometimes patients may go to different doctors and they're prescribed one thing and they go to another doctor for another condition. So there are all of these issues, and sometimes there can be interaction between some of the drugs and just so many drugs. Reduced energy level, that's often a complaint. Malnutrition, basically from an unbalanced diet. Constipation is something that is often an issue. And the other thing is an inadequate fluid intake. We often can't depend on the elderly to drink when they need to. the business of thirst becomes a little complicated. And so they have to be encouraged to drink without depending just on thirst. And that, of course, is tied in with the business of constipation, because if there's inadequate fiber, inadequate fluid intake, then that can be one reason, as well as side effects from some of the drugs that they may be taking. So what do I mean by the chronic nutrition-related diseases, including the risk factors? So there's type 2 diabetes, hypertension, high cholesterol, high triglycerides, which in fact is an independent risk factor for cardiovascular disease. So in terms of heart disease, what we'd be looking at and considering would be coronary artery disease and sometimes heart failure, especially in persons who have had hypertension for a very long time. Stroke, osteoporosis, that could be a biggie, arthritis, something that can make such a difference to a person's quality of life and to the nature of what they eat and the variety of what they eat. Sometimes just opening a jar is an almost impossible task. As far as malnutrition goes, poor oral health, something that we sometimes don't think about. And we'll see that poor oral health is in fact can be associated with heart disease. Cognitive impairment, mental health issues such as depression, an unbalanced diet, poor food choices, and inadequate help for food preparation. In terms of dental hygiene, it has been found that the bacteria from the inflammatory process that takes place in the gums, when those bacteria get into the bloodstream and the arteries, they can in fact lead to an increased risk of heart attack and stroke. So the recommendation is that your teeth should be brushed at least twice a day, and flossing should also take place daily. What are some of the possible issues? Changing body composition. With all of the hormonal changes, estrogen is reduced. Very often we find that there is a decrease in lean body mass or muscle tissue, whereas there's often an increase in percent body fat. And so that's one of the reasons why in this presentation, I thought I wouldn't get into the business of BMI and so on, because for the elderly, they're often an exception, because BMI is not necessarily a good proxy for percent body fat because of this changing body composition, which often takes place as persons age. Lots of hormone changes. I mentioned estrogen, but there are lots of others, progesterone, testosterone, and osteoporosis, and very often a decreased metabolism. Sometimes depression may be missed by family members and so on. Very often when we think of depression, we think that persons are going to necessarily look sad. Well, sadness may be a symptom of depression, but there are other symptoms, things like irritability, sleeping issues, the person's not thinking and at the rate at which we would expect them to. Anger, sometimes persons respond with anger and we can't understand what it is that has changed in their lives. They seem to have everything that they need, but they're irritable and angry. Lack of pleasure in things that once gave them pleasure. So those are just some of the issues. What are some of the nutrients that we have to pay attention to, that we need to prioritize as persons get older? Calcium is one. Vitamin D is one. And very often the elderly they have a higher requirement for calcium, because when you're younger, you make deposits as you take in calcium, whether from food or supplements. As you get older, your requirement is actually higher for calcium to prevent things like osteoporosis. Vitamin D, very important to aid the absorption of calcium, and for other reasons such as your immune system. Vitamin B12, as persons get older, the business of absorption in the gut is often compromised, not as efficient as it used to be. And vitamin B12 is one of those things that is sometimes not adequately absorbed. And sometimes the medication, for instance, something like a drug like metformin that lots of adults are on if they've got diabetes, and the requirement for vitamin B12 is increased because of the depletion by the use of some drugs. Sometimes there's an inadequate protein intake. Protein is one of those macronutrients that very often requires preparation, cooking. Now, the things that you find that are very easy to prepare are things like bread and crackers and snacks. But when it comes to having to prepare and cook and cut up and season, may be not as easy to get done. And so the protein intake may be inadequate. And we should also pay attention to something like the that says omega-2. That should be omega-3 fatty acids, which we can get from foods. And if not, then we can definitely get from supplements. But that is one nutrient that you can get. We have no issues getting the omega-6 fatty acids, but the omega-3, not so much. We have an abundance of omega-6 from sometimes the oils that we use and so on, but the fatty fish and that sort of thing, we may not be able to get an adequate supply of. We find that with the Western diet, these are some of the issues. High in saturated fat and trans fats, lots of added sugars, high in salt, especially in the Jamaican diet, and we can all stand accuse some of the things that we love that are naturally high in sodium. And that shift has taken place from the traditional diets, which were much higher in fiber, the fruits, the vegetables, the legumes, the peas and beans. The traditional diets were based on whole plant foods, not such refined foods. And they were very much higher in antioxidants. And these things we have discovered are actually neuroprotective and so very important in the diet of the elderly. The blue zones, I thought I would put this in. What are the blue zones in the world and what is the importance? These are regions of the world where people live the longest. They have the highest percentage of centenarians. And not just centenarians, but centenarians who are thriving in their old age. This is a book whose author, Dan Butner, is absolutely worth reading. And what we call the blue zones, these regions are Okinawa in Japan, Sardinia in Italy, Loma Linda in California, the Nicoya Peninsula in Costa Rica, and Icaria, an isolated Greek island. What are some of the takeaways from these blue zones? A very and highly plant-based diet, small meals, lots of leafy greens, for instance, spinach, kale. I'm sure callaloo would be in there if we were in any of those territories. Seasonal fruits and vegetables, beans, whole grains, lots of fish, especially I just spoke about the omega-3 fatty acids, which are present in the oily and cold water fish. So things like sardines, anchovies, cod, very important. Very sparing use of especially red meats. The use of plant oils and much less use of animal fats. Olive oil has been found to be most often used in these blue zones. Nuts and seeds are favored. There's very little sugar in the diet, and the beverage most often consumed is water. Happiness. This is a quote, a quotation that I rather like. Happiness is like a butterfly. The more you chase it, the more it eludes you. But if you turn your attention to other things, it comes and sits softly on your shoulder. I just thought I would include this. And the business of happiness. We're talking about this holistic approach as we are engaged in the care of the elderly. There is a Harvard study on happiness, which followed people for more than 75 years. And what was most interesting, the single most important determining factor for happiness is human relationships. Other predictors were gratitude, being able to let go of the past, and being able to look forward to the future. What are some of the strategies to improve the nutrition in the elderly? Prepare nutrient-dense meals. Use herbs and spices, and this is a good way to reduce our sodium intake. There are some products on the market that utilize just herbs and spices and no sodium at all. But even at home, even in that salt cellar, add some herbs and spices to your salt cellar, and in that way, reduce your use of sodium. Make meals colorful and appealing. Prepare small meals. Very often, the elderly do not want to eat large meals. Sometimes poor appetite may be an issue, but you can probably have them have smaller meals and include a few snacks. Make mealtime a social occasion. Now that was a big issue in the blue zones. Eating is a social occasion. Very often people don't sit and eat by themselves in their homes or in their apartments, but families eat together or as friends, and it really can be a fun time. Using supplements if necessary. Sometimes if it's impossible to get the nutrients that we need from the amount of food being consumed, then we may have to utilize supplements for things like vitamin B12, maybe calcium, whatever the needs are. And the last thing I have on this slide is get help. Sometimes with the best will in the world, families want to do the best, but not recognize that older persons may need help, especially when it comes to the business of food preparation. And when we think of some of the chronic nutrition related diseases and the effect it may have on the elderly, they very often, one of the most important things that you can do for them is get help. I've had family members bring elderly parents and they want a meal plan designed for whatever the issues are, whether it's diabetes or the person has had a stroke. But no matter what meal plan I come up with, if that elderly person does not have help in food preparation and the serving of meals and that sort of thing, then it really is not terribly useful. Now, these are the basic food groups in the Caribbean. I'm not going to go into them, but it's the basis of any meal plan that I prepare, because it has to be foods that people are familiar with. I want to say afford. That's a sore topic these days with the rising cost of foods. But when you look, for instance, at things like legumes or peas and beans, we can still come up with the right combination of foods, high in fiber, with lots of color, supplying all the macronutrients and micronutrients needed based on foods that we can access. The basis of a healthy Jamaican diet. It's a balanced diet with a regular consumption of lean protein sources, healthy and essential fats, vegetables, and complex high fiber carbohydrates. And what are the high fiber carbohydrates? Legumes, peas and beans, again, grown provisions, and often fruit. Sometimes we don't recognize that carbohydrate foods, that fruits are carbohydrate foods, and that legumes are carbohydrate foods. We tend to get the ground provisions and so on. We know that those are carbohydrates, it's starches, but sometimes we don't recognize that fruits and legumes are in fact carbohydrate foods also, especially when we're doing meal plans for persons living with diabetes. Fluid is very important, especially in a hot climate such as Jamaica, and with increased sweating and electrolyte loss, we have to pay attention to that. A good guide as to whether persons are getting adequate fluid is to look at their urine, and it should be almost clear. A good rule of thumb is 6 to 8 glasses of water per day. And depending on the calorie requirements, because we don't just get fluid from water, we get fluid from other drinks, other beverages, teas, and so on. We get fluid from fruits and vegetables, which have a high water content, things like oranges, watermelon, cucumber. There are lots of other ways that we use to complement just taking in water, especially if we're trying to increase calories. I thought I would just share a little video. Well, those two elderly persons certainly had some fun, and I hope you had a little bit of fun watching them. So then, health does not always come from medicine. Sometimes it comes from peace of mind, peace in the heart, peace in the soul, and it comes from laughter and love. Physical activities. For health benefits, physical activity should be moderate or vigorous and add up to at least 30 minutes per day, most days. It doesn't have to be 30 minutes of continuous activity. It all adds up, even if we do 2 15-minute segments or 10 minutes, but just increasing our physical activity. Some of the changes, benefits of exercise, I should say. Endorphins, the release of endorphins, which are specific brain chemicals which can help to change our mood. Increased brain volume, a reduction in stress. Exercise, physical activity helps to prevent and control the chronic nutrition-related diseases, especially diabetes and hypertension and high cholesterol. It improves glucose tolerance and reduces insulin resistance. It increases lung volume. It is even thought to help in the, to assist in the reducing the risk for some cancers. The weight-bearing exercises certainly help with preventing the rapid decline of bone loss, and so helps in preventing osteoporosis. And even back pain relief is thought to be helped by exercise. And we can choose exercises depending on what the elderly person is capable of doing. In summary, therefore, in order for the elderly to enjoy life, the need is not only for long life, but for good health. This requires a holistic approach: good nutrition, consistent physical activity, good mental health, social interaction, choose happiness, and adequate rest. Thank you very much.
Thank you to Dr. Joy Callender for this very, very interesting and educational talk on holistic nutrition, holistic care, not just nutrition in the elderly. And may I just say, happiness is soul food. So yes, it's just key to having a balanced and enjoyable future and being able to appreciate. I think happiness is brain cells. Happiness is everything that's positive. And so it's a food of its own. Another point we took from you, Dr. Callender, is the need to eat together as we grow older. That need to share, again, that joyousness and care that comes when we are with each other. And the occasional need for supplements. I noticed what you said about noticing when our elderly need help. Sometimes they're not eating because they can't do things like they can't open the bottles to fix various foods, or the food in the fridge. You notice that the food is left in the fridge. So you notice that's a sign that something is happening. The food is not being used. There's a reason for it. Or if the regular burning up of foods, and so sometimes they just can't cope with that, and they need family members to supply food for them. So there's a lot of stuff, Dr. Callender, that you spoke to. Of course, the regular elements of the good diet, and how this helps to prevent cognitive decline. It was wonderful to hear about those blue zones, the blue zones. So we can all go look up the blue zones and see how these people make aging work for them. So that's a thank you, Dr. Callender, for your time this evening. And we'd like to proceed to the Q&A. I hand over to Sam for this.
Thank you so much, Doc. So the first question, is it recommended that the elderly take cod liver oil tablets to supplement their diets?
I think that's a reasonable recommendation. Some people, if you're getting the nutrients from your foods, then you don't need these things. But I think for the elderly especially, and for all of the things that those omega-3 fatty acids can do, which is what cod liver oil can give you, I think it's well worth taking it as a supplement. It helps to keep the blood thin. It helps improve your mood. It helps with keeping your cholesterol levels in check, just to name a few. So I think it's one of the supplements that is probably worth taking. And there are other sources of omega-3. It doesn't just have to be fish oil. You know, they're cod liver oil. You can get it from other sources.
Thank you so much. The next question says, Dr. Callender, I applaud the half plate veggie and fruits, but what is the thought of fruit veggie combination? Are there fruits and veggies that should not be eaten at the same time?
This is something that I come across a lot. There is really no scientific basis for a lot of this. Your body produces all of the enzymes in the right order, depending on what you eat, to digest things, to absorb them. Fruit may be digested more quickly, but then it moves along the gut and absorption takes place. So this business of not combining specific fruits and vegetables and that things will stay in the stomach and rot, there really is not a lot of evidence for any of that. If there's any food that you're intolerant of, then simply don't have it. You may have reduced enzymes to digest it, and so you may have developed an intolerance over the years. Now, in terms of food combinations, that can be very important, especially for, let's say, diabetics. If you eat carbohydrate foods and you have them in combination with protein foods, and you have them in combination with healthy fats, you actually slow digestion and you reduce that blood sugar spike and resulting insulin spike that takes place. So that has to do with a specific issue such as blood sugar and insulin spikes. And I'm saying that you may need help to put these foods together, recognize which are the carbohydrate with the proteins and so on, and come up with a meal plan that gives you the nutrients that you need. I hope that answers your question.
I think that was a wonderful answer, actually. I see one here that says, what would you suggest for a physically disabled elderly client who drinks at most 1 liter of water per day, does not take adequate amount of fiber from the diet, but complains of chronic constipation? Is there another way to assist this client?
Yes, there's always a way. You know, it involves looking closely at what that individual takes in over 24 hours, over the time that they're awake, and see how we can increase, get them to have fluid, if not from water. Remember, I said we can enhance our fluid intake from certain foods. And if the addition of a bit of salad, a bit of, I mentioned some of the fruits, especially like oranges, citrus fruits, fruit juices, see how best we can increase fluid intake as well as fiber. Things like nuts and seeds are high in fiber. I always encourage more use of the legumes. We're always talking about the business of cost and the budgetary constraints, especially in this post-COVID-19 era. So I hope that I can, that answers or gives you some ideas, including things, maybe something like Metamucil for fiber. But when you use these things, you must increase the fluid intake. Otherwise, it really is counterproductive. Things like flax meal and these sorts of things, things like yogurt and probiotics, all of these things can help with the business of constipation and gut health.
Thank you so much. So because of time, I think we'll have to cut it here, though there are many, many questions there. Thank you so much, Dr. Callender. If you look in the Q&A, you'll be able to click on type answer and type an answer to each of the questions that are there. Thank you so much. Back to you, Dr. Brown Morgan.
Thank you, Dr. Callender. As usual, many questions require your answers. So please go ahead and answer in the Q&A.
I will do my best.
Right. And we'll also remember that the medications can cause constipation. So we might need to have a look there. It is surely a pleasure to introduce to you tonight our sponsor, INDUS Pharma, who is presenting for INDUS Pharma.
There's a recording that I have to play.
It's a recording. Is it from Mr. Dare? Okay,
yes.
Let us go ahead and listen. Thank you, Sam.
Welcome to the world of INDUS. And we are happy to join hands with you to serve the humanity across the globe through innovative healthcare brands. In just 16 years, INDUS has grown from 1 to 120 products in 12 therapy areas. Today, INDUS has spread its wings globally and is now present in 30 countries with 150 professionals spread across geographies like Asia, Southeast Asia, Africa, Europe, Caribbean, and South America. Excellence is not an act, but a habit at INDUS. Our world-class products, affordable pricing, excellent supply chain, strong field force, and good business practices have accredited INDUS with many excellence awards, like Federation of Indian Export Organizations Export Excellence Award, Farm Excel Award, Brand of the Year Award in Ghana, and State Bank of India Financial Discipline Award. What's more, now INDUS brings you a 5-minute miracle. In today's fast and modern lifestyle, the incidence of heartburn due to acid reflux and Gerd is alarming due to stress and busy schedules, overeating, eating irregularly or too quickly, eating just before bedtime, fatty, spicy, and fried junk foods, caffeinated drinks, carbonated soft drinks, acidic juices, and alcohol, and smoking. As published in many international journals, hyperacidity, acid reflux, and Gerd lead to heartburn. In hyperacidity, the excess acid from the stomach can move upward into the esophagus, known as acid reflux. As the lower esophageal sphincter, which joins the esophagus and stomach, becomes weak. Since the esophagus is not well protected like the stomach, the acid can irritate the lining and cause inflammation in the esophagus. This causes painful symptoms that can last for a few minutes to hours and can occur more frequently within a week. This chronic form of acid reflux is known as Gerd, that is, gastroesophageal reflux disease. The major symptoms of heartburn due to acid reflux and Gerd are a burning feeling in the chest, epigastric pain, a bitter or sour taste in the mouth, nausea after eating, regurgitation, frequent burping, flatulence and gas, stomach discomfort, difficulty in swallowing, sore throat and dry cough. The question now is, do regular antacids help? In hyperacidity and Gerd, regular antacids can only neutralize the acids, leaving acid reflux unattended. To treat hyperacidity, acid reflux and Gerd, INDUS Life Sciences comes with a unique third-generation antacid named NewGel, which controls acidity, prevents reflux. NewGel offers balanced combination of alginic acid, magnesium hydroxide, dried aluminum hydroxide, magnesium trisilicate, and dimethicone. When a person takes NewGel, the raft-forming alginate physically blocks reflux through a unique mechanism. When alginic acid comes in contact with the gastric acid, the raft-forming alginate, which includes natural algae, begins to form a light but strong foam barrier known as raft. This raft floats on top of the stomach contents and prevents acid from moving upward to the esophagus. The alginate raft formula, containing balanced antacid components, offers a speedy onset of action in less than 5 minutes and provides rapid relief from acid reflux with effective neutralization of stomach acid. NewGel has long-lasting effects up to 4 hours, since the raft can be retained in the stomach for several hours. Dimethicone in NewGel is an anti-foaming agent. It reduces the surface tension of gas bubbles, causing them to combine into larger bubbles in the stomach, which can then be passed more easily by means of belching. Dimethicone thus relieves flatulence. Nugel is recommended in hyperacidity, Gerd, gastroesophageal reflux disease, gastritis, flatulence, and as an adjuvant to NSAIDs. Nugel is available as Nugel 200 ml suspension and Nugel tablets with delicious mint flavor. Nugel is safe in pregnancy. Nugel is sugar-free, hence safe for diabetics. For patients with symptomatic pain due to gastric and duodenal ulcer, INDUS also presents Nugel O, the alginate raft-forming antacid with mucosal anesthetic agent oxytocin. Oxytocin is a potent, safe, local anesthetic agent that provides prolonged anesthesia of mucous membranes, thereby offering prompt and prolonged relief of pain. Nugel O is available in 200 ml suspension with mint flavor. Nugel and Nugel O. Raft formation reduces intensity and frequency of reflux attacks. Works in less than 5 minutes. Offers long-lasting effect up to 4 hours. Sugar-free, hence safe for diabetics. Delicious mint flavor improves patient compliance. We thank the entire medical fraternity for supporting INDUS in our journey towards better healthcare.
Aminopep-4 in geriatrics. Aging is associated with a progressive loss of muscle mass, which increases the risks of injury and disability. A 2018 Journal of Nutrients highlights that inadequate intake of dietary protein has been linked with poor muscle function and physical decline in older people. Essential amino acids, which cannot be synthesized by the body, have primary role in the regulation of muscle protein synthesis, can potentially mitigate the loss of muscle protein during aging process. To meet the increased demand and to promote nutritional status, INDUS Life Sciences brings Aminopep-4. Aminopep-4 contains all 10 essential amino acids enriched with multivitamin and zinc. During aging, supplementation with essential amino acids stimulates muscle protein synthesis in the elderly, increases lean body mass, improves the ability of walking, provides immunity against recurrent infections, and builds up energy and vitality. All essential amino acids in Aminopep-4 are in free form, which does not need further digestion and hence can be directly absorbed. Aminopep-4 is also suitable in compromised digestive capacity. Aminopep-4 offers adequate nutrition through essential amino acids and is an essential part of healthy geriatric phase. Aminopep in convalescence. Following illness, body proteins like enzymes and hormones are rapidly broken down and are insufficiently resynthesized due to lack of essential amino acids. During convalescence, there is rapid weight loss due to loss of body fat and skeletal muscle mass. This is frequently accompanied by short-term self-limiting disease process like injury, surgery, and infection. Hence, supplementation with essential amino acids promotes tissue regeneration and healing, shortens convalescence, strengthens immunity, and provides sense of well-being. Aminopep-4 supplementation strengthens body resistance and improves immunity. Aminopep-4 shortens recovery phase and hence back to work faster. In old age and convalescence, Aminopep Fort acts as an ideal nutritional supplement.
Yes, we'd like to thank Indus Pharma for their support for this conference this evening. We know we can depend on Mr. Daya and Indus very regularly. We thank them for the support this evening. So it is for me now to just ask Professor Denise Eldemire to come to the podium, as I may suggest, unmute and that's your video. There she is.
With the light behind me.
There, welcome. It is my true pleasure to introduce to you Professor Denise Eldemire-Shearer, who is, we all know here in Jamaica. She works with the University of the West Indies, and she's a professor of public health and aging. And she's a director of the Mona Aging and Wellness Center at UWI, which we know has been giving human assistance to the older people to get their vaccinations over the last nearly 3 years, or 2.5 years. And she is also involved not only in the teaching of our doctors, but in the teaching of Jamaicans, trying to show them the value of caring for our elderly and helping younger people to understand the needs of the elderly, which sometimes they just don't get. It's just not the same thing. So Professor Eldemire-Shearer is a medical doctor and I saw this somewhere, the island's resident aging expert, because that fits her to a T. And she has spent decades engaging in researching, listening, working, and developing policy on behalf of Jamaicans over the age of 60. She has represented the old and the aging at every level within our society. And Professor Eldemire-Shearer, working at the Mona Aging and Wellness Center, does research in public health and geriatrics. And a project that I saw here, which is something that she really cares about, is the introduction of geriatric care into primary health care. Now, as we all know, the hat that Professor Eldemire-Shearer wears is that she's also the widow of the Honorable Mr. Hugh Lawson Shearer, past Prime Minister of Jamaica. Just to mention that, because she's one of our darlings. She is chairperson of the National Council for the Senior Citizens, and director of the World Health Organization Collaborative Center on Aging and the Elderly. And she's a chairperson of a more recently formed group some years ago, the Caribbean Community of Retired Persons. So I just would like to just say over to you, Professor Denise Eldemire-Shearer. You are going to talk to us about medical issues in vaccinating the elderly, and we are here to listen.
Thank you very much.
We're hearing you clearly, Doc.
Everybody can see now and hear. I noticed in the last, there were some hearing issues. Everybody's hearing okay?
Yes, Prof, we can hear.
Yes, Prof. Yes.
Thank you very much for this invitation to share in what, yes, has become quite a passion over the last couple of years since COVID visited our shores. Sorry. Sorry, we're trying to get organized here. So I'm going to give some basic concepts on aging and immunity and the relationships. Some of this obviously has been mentioned previously, and I can go over the slides fairly quickly. Threaded throughout my presentation or my talk is going to be the whole issue of COVID and the focus. I'm going to use COVID as my main focus to talk about vaccination in older people. We will look at vaccines and what is happening, and we will look at what we can do. I thought we could cover some basic concepts, although most of it has been covered in Dr. first presentation. But let's put aging into the mix, because we speak about medical issues and we speak about the immune.
Hi, Prof. Sorry to interrupt. So the presentation is currently showing your slide view, which your presenter view. At the top of your page, you should see where it says display settings. Could you just
I'm not
click on
hearing
that
you.
for me?
Can you speak a little louder?
I can. I apologize. Are you hearing me better now?
Yes.
Apologies for interrupting. So it's showing your presenter view at the moment. At the top, you should see where it says display settings beside show taskbar. Could you click on that one for me? Not the taskbar, display settings.
Yes.
That one beside it. When you click on that, it should give you an option to switch from presenter view. Tell you what, let's do it this way. Okay, you found it. All right, swap presenter view and slideshow. That's exactly what we want. Ah, perfect. Here you go.
We're good now?
Perfect.
And thank you very much.
No problem at all. I apologize.
That's fine. No, we needed to get it right. So I think one of the things that we need to take into consideration when we're talking about vaccines, etc., even about medical issues, is what else is happening. The emotional bits that Dr. Callender just covered so well, but also the spiritual and the social. We found this very interesting in our vaccine work. If you look at the figures, you will see that a lot of older people did not take Johnson & Johnson. And it had nothing to do with Johnson & Johnson, but they told us that they'd never had a vaccine that was a one-off. So they wanted something that had 2 doses based on their previous experience with children, etc. So these are things, the aging process does influence how people think and how we need to interact with them. So this was mentioned earlier, but look at all the things that you have to think about with the aging process when you are thinking about immune function. And we have been having this discussion. Who needs a first booster? Who needs a second booster? And you just heard the discussion about pertussis. So, none of us, I agree with Dr. Brown Morgan, none of us had ever thought about pertussis and a follow-up shot. But we do know that the immunity does decrease. And most of these things are age-associated. So what are some of the aging changes? That persons are slower to respond. We certainly saw that in the responses to COVID. We would have older persons, and everything I'm speaking about speaks to the older person, where the person seemed all right and then suddenly got sicker. The strength of the response to the vaccine and to treatment is decreased. There's slower healing due to us having fewer immune cells. Think about flu, which is also one of those we should be vaccinating against. So many older people take 2-3 weeks to recover from a flu-like illness, whereas when you're younger, it's a couple of days. And these aging changes also spill over into other illnesses like cancers, where our body is not able to recognize the defect in the cancer, and therefore sometimes late presentations. The impact of the aging changes with immunity or on immunity are increased susceptibility to both infections and to cancer, and there can be increased autoimmune disease. But infections are significant not only because they can be severe in older persons, but as I alluded to, they also contribute to decreased functional capacity post-infection. One of the things that we aim for, in addition to what has been already presented with delivering care to older people, is maximum functional capacity. We want our patients, clients, to be able to function as independently as possible, even if that means using a cane, having various devices. Infections tend to reduce this capacity. Think about your patients. I have a patient that was in hospital recently for 3 weeks, somebody who's very fit, and it has literally taken them 3 months to get back to where they were beforehand in terms of their activities to daily living. We also find that there's an impact on the aggravation of certain chronic diseases. And we saw that what was very interesting in our first presentation, if you go back to the slide that she had, or think about the slide she had about the conditions that make pertussis worse, they're the same conditions that we've been talking about for COVID. So there are similarities in the diseases for which vaccines work. But our immune system is not isolated, and you will find that smoking, alcohol, poor nutrition all affect the immune system. And for us, the medical condition of frailty, which we see in particularly the over 80, the loss of muscle mass, the loss of the grip, and you can tell about that, and basically being a little more shaky. And I'll bring it all together in this slide, and this is more for you to have. I'm not going to go through it in detail, but it brings it all together to show that it's a circle and it goes backward and forward. So you may have 3 or 4 things impacting on it, on your aging process, and therefore your immunity, your protection, but you may have 6, and it goes back and forth. Today, you may have 3 or 4, your diabetes flares up and you get problems with the glucose regulation, which does also impact the immune system. And you will find that it's not a static situation. It can be very static, which means that you have to interact with your patient whenever they come to see you. But aging also presents us with challenges to how things present, how our infections present. I've put up the whole slide, but I really want to draw attention to pulmonary, the blunting of the cough and the other reflexes. How many times is it that your patient with flu does not seem to be very sick and then suddenly gets sick? Same thing was happening with COVID. It was in day 4 or 5. I had a patient that her son spoke to her the afternoon at about 5 o'clock, and she seemed fine. And she just suddenly went downhill the following day when everything cascaded. These are some of the things that you will be challenged with because of the aging process. The central nervous system I also wanted to bring up and to highlight because, and I will go back to it in a later slide when we look at dementia, the blood-brain barrier is much more able to have things transmit across it. And therefore the infection goes quickly to the brain in the older people. And again, I'm sure that you know of persons with COVID that seemed very confused, very out of it. We unfortunately have a couple of these patients that have formed the part of the group suffering from long COVID, and they have ended up with other problems. This one is critical, and I think one that we don't think about enough. It used to amuse me having my temperature taken. I'm now 70. Baseline temperature in older people is lower. So if you are waiting for your patient, your family member to present with a fever because they have an infection, you're going to have a long wait. They are much more likely to present being a little confused, a little off, maybe off their food, but certainly just off. They're not their usual lively self. So again, you need to be aware that the infections, the diseases that need vaccinations will have different presentations in older people. So where do we go from here? Are vaccines necessary? Do older adults really need vaccines? Basically, most older people and a lot of us physicians really don't think about vaccines for the older person. We think they're for children or those with poor health, but we've heard today of the importance of pertussis. I find the discussion around pertussis very important because I was actually going to highlight the need for the tetanus. Many older people are in their gardens, they have animals, they are exposed to the risk of tetanus. So I was actually going to have a plug for making sure we did do I was going to say TED Talks, but now I'll say DPT based on our information tonight. The flu vaccine, when you look at the deaths due to pneumonias and to chest infections, 90% of them are in older people. They're no longer in children. And therefore, we are not doing enough to promote flu vaccines and pneumococcal vaccines in our older patients. This is another thing that we need to think about. Why vaccinate? It's an important medical intervention. We don't want to only cure disease. We'd rather our older people not have disease, but also important, protect others around them. We have younger children who cannot have COVID vaccines yet. And most importantly, older persons with chronic disease are highly susceptible to the vaccine preventable diseases. We all have seen shingles in an older person. We know the pain of shingles. We know the duration of it and that it lasts weeks, even years with that chronic neuropathy from it. So why not prevent it? So much easier. Now, we don't have the shingles vaccine here, and I'm making a plea here that it become available. Yes, it will be expensive because it's expensive in the US, but I think we need to make it an option. And I've said this, this slide we now need to highlight because I've been given the information, we have been given the information, the protection from some childhood vaccines may not last. So this is very important, and it's in our best interest to take charge of promoting the preventive health of our older people. So what are the adult vaccines? Some of them we've heard of already for this evening, certainly the TDAP. The flu vaccine, the uptake is really not what it should be, and that one is not too expensive. Shingles, we do have clients, patients that travel. I certainly recommend it. I have taken it. I've seen too much shingles in my practice and the distress caused by it. The pneumococcal vaccine, we have people with chronic lung disease, we have people with heart problems. The pneumococcal is a one-off, so those are the sort of things that we should be promoting. And of course, now the COVID-19. So let us look a little bit at COVID-19. It's the prototype now of the infectious diseases that we can prevent. We are now able to give the second booster to the population over 60. And interestingly, they have added the diabetics, and somebody asked earlier about renal disease. They have added the renal disease to this go round of those who can have a second booster, as well as the hypertensives, as well, and even if they're not 60. Is it important? These are the international figures, but I will show you ours. COVID-19 is killing for 13.4% of patients over 80, compared to only 1.5 of those in their 50s. Clearly, older people are more susceptible to the issues and to the severity of the COVID infection. And that's because of the changes in the immune system, which are aggravated or doubled up by the changes in the aging system. This is the death rate that we see, 14.8%. This is our situation, but let me bring this one up. And I'm conscious here of time, but you can tell me to slow down if I need to slow down. We can see that the cases, because of the measures, were not quite as high among the over 70s in particular, because remember, they were on the lockdown. So we didn't see that many cases, but look at the death rates. Look at the death rates. So if you needed an argument that you should recommend, push, advocate for the vaccine, this is it. From 4.1 in the 60 to 69, and these are the local figures, to 7.5 going up as high as 15% in the over 90. So we really saw the death rates due to COVID. So that is good enough, I would hope. What's the right word? Motivation to encourage the vaccine. So these are the comorbidities that we found were contributing: the cardiovascular disease, the diabetes, chronic respiratory disease, and hypertension. Obesity, we didn't have the actual figure, but it certainly played a critical role. And in some of the international studies, it's as high, it's actually higher than the diseases. And there's a reason for it. The studies have shown that in obesity, there's a change in the distribution and number of the immune cells as they are sent to other parts of the body, and they get into adipose tissue and not able to fight. So how do the changes associated with aging and immunity impact and interact? We see decreased pathogen recognition and macrophage activation, i.e. a slower response. We see a reduction in the natural killer cells cytotoxicity, so there is less response. It's manifest, as I mentioned, as an acceleration of COVID-19 in early stages and excessive lung damage in the later phases. So persons will seem to be doing all right, and if they get through that first phase, they seem to be recovering, requiring less oxygen, and then it's suddenly downhill. And that's due to the cytokine storms from the prolonged activation of the inflammatory signals that then leads to the hypercoagulation in the small blood vessels and those problems. You can end up with DIC, multi-organ failure. And then you have the decreased pools of the T cells, which are also playing a part in the aging process. So the medical issues we've seen are the individuals with comorbidities, including hypertension, diabetes, and cardiovascular disease and obesity, contribute or can contribute. And the next line will show you why I say can, to the severity of the disease. persons with these comorbidities, and by the way, older people don't know what a comorbidity is. When we gave them the form and they would say, but what are these? We need to use simpler language. We had to change in the vaccine center to asking, do you have any other illnesses? Intelligent persons with a university degree couldn't answer that question on the form. Our form is very convoluted and long. And yes, you still have to fill it out for the second booster. So you fill this form out 4 times. But what is important is as older people get older, you can't measure how old they are by their age, because you have some very young older people, but you equally have people who are biologically older because of the ravages of the chronic diseases than their chronological age, and they're therefore at higher risk of severe disease. I am sure that unfortunately, some of you had persons who were in their 40s and 50s that had very severe disease, but who were obese and had diabetes and that sort of thing. So all these medical issues come over into your need to vaccinate. The system is, my pauses are, the system is not changing as quickly as I would like. Let us also think about the special groups within the group of older people, because we found there were persons with disabilities. ECLAC, which is a Caribbean organization, in early April highlighted these issues, that we weren't seeing them. We had no idea how much COVID was there with persons with disability, and we weren't seeing them in the vaccine centers. Persons with hearing difficulties weren't able to understand our messaging in the center. Also, persons with sight difficulties came with caregivers, and most of the centers were saying people not being vaccinated couldn't go into the room. There was one situation we had that made me wonder about it. The person who came with, this is when we're doing the over 60s, and it was a gentleman who had impaired sight. The caregiver was 56 and technically did not qualify to be vaccinated, but she was doing everything for him. And these are questions and these are concerns that have come up during our efforts at vaccinating. The social distancing can severely impact persons with disabilities. They're dependent on others, and they are at increased exposure, especially when the others are going out to do other things or have children to look after, etc. We picked up on the mental health aspects of COVID. We are talking about medical conditions, and mental health has been a very, very important part of our fight, not only with COVID, but if you think about shingles, if you think about the other diseases we deal with. And WHO identified early the mental health impact on older persons: confusion, anger, indifference, a lot of anxiety. We did 2 studies, and the anxiety was more about the fact that not everybody was paying attention and they were exposing them, the issues around caregivers. We are seeing the issues now. Dr. Callender's presentation hit home the social isolation that is associated with loneliness, anxiety, loss of muscle mass, and increased frailty. But one of the things that struck me during COVID, and it can be extrapolated or extended to other illnesses, I never appreciate that what we go through from the time a person dies till the time a person is buried is actually a process of grieving and accepting. Now the person dies, you don't say goodbye, you cannot have a funeral, and there's a lot of anger, what could I have done? And there's a lot of sadness as to the fact that people were not able to go through that 9-night and that grieving process. And I never appreciated how important and how significant it was until COVID. We have another group of persons. Dr. Callender mentioned them. I want to take them further. This is a group that for all of our vaccine preventable diseases that have additional concerns. They have difficulty understanding information and facts. I already pointed out that fever is not the major presenting complaint in many cases. It's confusion and delirium, etc. And these people are confused to begin with. How do you pick up that they're sick? How do you pick up that they're needing to be cared for? They do not keep on their masks. They don't socially distance. They do not understand when you take them into an office why everybody has on these masks, and they can really react badly. So it's a group that we need to take into consideration and to be careful how we are, and to ensure that we are meeting their needs. Their caregivers were disrupted. They didn't have the usual caregivers, and so there were issues. So, do the changes associated with immunity affect vaccines? Yes. You heard that in the first presentation, but the decline not only decreases the ability of the body to fight, but it decreases the effectiveness of the vaccine. And therefore, this is the argument for the boosters. We have no idea how many boosters we are going to need and whether it's going to be an annual event. We know with H1N1, it's now in the flu vaccine, so we know we are getting it. And studies are showing that the need for boosters is important. Fortunately, the elderly are responding. We're still nowhere near where we want to be, but yes, older people are getting vaccinated more than the general population, thank heavens. We're still doing 40 or 50 a day for the second booster. We were down to 10 and 12, so that's something. So as I come to the end, the other points, vaccine hesitancy and mistrust is a problem. We are seeing it. There are people that don't understand. Somebody said to me, why did we call it a vaccine and not an immunization? What was the difference between vaccines and immunizations? They're used to immunizations. They're not used to vaccines. Of course, they don't know that a vaccine is an immunization. Will my comorbidity increase the risk of an adverse reaction? That we got a lot in the vaccine center. Can I take it or should I not take it? And the studies are actually showing that there are decreased reactions with increasing age and that they are safe. And frailty can decrease the older person's response to a vaccine, but it's not a reason to not vaccinate. So we need to think, and although I've highlighted COVID, please, flu, pneumococcal, shingles, now we need to add the DTaP to this as well as the illnesses we need to vaccinate. And I have put up my references. And thank you.
Thank you so very much, Professor. My phone, as we've just had a little glitch, power back on, but not booted up yet. So I'll convert over to the computer in a little. I'd just like to thank you again, Prof, for just this exposure, this indwelling need to understand how, although we're human beings, adults, aging adults are human beings, but yet their bodies are so different and their reaction to exposure to similar illnesses, diseases, infections are so different. I'd like to just mention a couple of things that you spoke to. One, the decreased functional capacity post-infections in older people, where they just have a reduced capacity to be themselves, to help themselves to post infections. It takes a longer time for them to be themselves. And you also spoke to something that many of us didn't know, just like how many of us didn't know that the pertussis illness infected adults so much. I believe that many of us never knew that the baseline temperature in older people is lower, which means when we're trying to track a fever, that's a problem in the older person. We just can't use the regular 99 or whatever. The other thing was that we need to be aware of the different presentations of infections in the elderly, especially the COVID, and how a person can be well or seem to be reacting well, and totally decompensate very quickly. So we need to continue to be very, very watchful and mindful of our older patients with COVID. And then you had a plug for the shingles vaccine, which you'd like to see come here. And so we will mention that, and we will mention that going forward. As you also mentioned asked us to remember to give our flu vaccines, our pneumococcal vaccines, and now the DPT vaccines, not just the Tetox, and our hepatitis, and of course, COVID vaccines. And in addition to that, you stressed on how our comorbidities as we age contribute to the severity of not only the COVID disease, but in all illnesses, in all infections. They decompensate and they make everything worse. So as you say, as older people become older, we can't watch for the chronological age anymore. It doesn't matter. What matters is the presence or absence of chronic diseases. And there, you said so much more, Professor Eldemire-Shearer. So we just want to thank you so much. We have taken many messages home tonight, and be blessed. Thank you so much for presenting tonight. And I would now take us forward. We're going to try to see what we can do here tonight. I'm holding my phone in one hand. So we now go to our next presenter. We will have two more presenters before we have a slightly longer Q&A. So please put your Q&As for Professor Eldemire-Shearer in the Q&A so we can get back to it in a little time. All right, it is now for me to welcome to the stage, to our podium. No, this is Mr. Chukwuemeka Cameron, an attorney at law, who is going to talk with us on legal issues in vaccinating the elderly. So, Mr. Cameron, could you please come online for us? Can we see you?
Good evening, good afternoon, Dr. Morgan. Well, good night, Dr. Morgan, and your all persons attending this.
Yes, good night to you. And we'd like to welcome the, is it 780 at one point? We've been doing very well with people logging on and participating tonight. Mr. Chukwuemeka Cameron is an experienced attorney with 21 years at the bar, and he has a history of working in regulatory compliance in the telecom and financial industry. I think we've heard from him, as the medical fraternity, we've heard from him before. His first name, I've heard that before, so it's not one that you can forget. He is skilled in privacy law, commercial law, and administrative law. And among other notable cases, he's been involved in the Privy Council case recently against Indicom, where he successfully filed 2 constitutional motions for privacy against the government of Jamaica. And in 2004, he received a master's in information technology and management from Erasmus University in Rotterdam, where he focused on data protection. And in 2019, he completed an advanced masterclass training as a data protection officer from an ISO certified provider, IT. And I see here Governance UK in the United Kingdom. Now, guess you're going to tell us what that's all about. And but his primary focus is now on design privacy, which I think this is his a business that he has, which offers data protection compliance training and consultancy services to companies, primarily in the private sector and in the financial industry, and in the information technology and services industries. And he founded this business in October 2019. And he has recently launched a podcast for those of us younger ones who get into social media and online and do these things in design. He has a show, Design Privacy Weekly. It's Design Privacy Weekly that helps businessmen and businesswomen and all businesses along the data protection compliance journey, which most of us have had a rough time taking on board and understanding. So he has been involved in other businesses as well, and there's another one called Jamaica UAV that offers digital. Is it orthomosaic maps and survey guides? So he's into such a lot. Anyhow, he sits on the disciplinary committee of the aquatic sports because he's very much a sports person himself. So this is the Aquatic Sports Association of Jamaica, because he's into aquatic sports and such. And he's a very healthy lifestyles oriented person. Right. And I guess I need to also say that, yes, he's a wellness buff. That's what I had made note of. And that he completed his first 70.3 Ironman triathlon in Augusta, Atlanta in 2019. So he's into serious training. And I would like to welcome him tonight, Mr. Cameron, to present to us on legal issues in vaccinating the elderly. Of course, I've heard from Mr. Cameron in other settings and other things that I almost felt scared in terms of what we doctors need to prepare for and be able to prepare ourselves for. So I wait to hear what he has tonight to tell us about what we need to be prepared for and prepare ourselves for when it comes to the manner of vaccinating elderly people. Over to you, sir.
Thank you very much, Dr. Morgan, and good evening to all attending. Don't go far, Dr. Morgan. It's 8:45 p.m. and so I'm going to ask for your company and possibly and participation in my presentation. So I will be, let me just start with a very brief presentation to contextualize it. And then I want to make this very, very practical. Let me share my screen first. share. And where's my slideshow? Right, so just going to contextualize my presentation. As an attorney, I have had cause to research the whole question of the right to privacy and how that translates to one exercising autonomy and how one is expected to preserve and respect the dignity of an individual. And that issue arose significantly in the question as it relates to COVID. Interestingly, we did not have a significant amount of litigation arising from COVID and the requirement that has been imposed in certain circumstances by entities to have a vaccination. More so, how that issue would impact on the elderly is the whole question of their ability to give consent. So I could have gone down the road where we have a very esoteric discussion about the right to privacy and the dignity of the human being and the type of constitutional motion you as doctors may be exposed to in giving vaccines. But I chose to take a more practical approach, which segues me into my presentation. So not only do we have a general right to privacy from our Constitution, but as of 2019, we had a decision coming out of our constitutional court that said a part of the right to privacy is the right to informational privacy. So before, when we're talking about administering vaccines, the issue before this judgment would have been the right to the dignity of the individual, to preserve the dignity of the individual and the right to allow that individual to exercise autonomy over his body. So that would have been the topical issue before 2019, before we had the NIDS decision. Coming out of this NIDS decision, none other than our Chief Justice said, informational privacy, which does not deal with a person's body, but deals with a person's mind, and therefore recognizes that an individual may have control over the dissemination of material that is personal to him. Unauthorized use of such information may therefore lead to infringement of this right. So why I've chosen to speak and focus on this informational right to privacy, because this is no longer esoterical. This is no longer an abstract legal concept that only lives in the Charter of Rights and Fundamental Freedoms. It has now been embodied in our Data Protection Act, and it goes into great detail as to what the right to informational privacy is, what rights data controllers have in relation to the rights that we enjoy, what rights it also articulates specifically, what rights we have, and they have appointed, and as of December 1, 2021, the Information Commissioner has taken her seat. And on that same day, it has been gazetted. So as I indicated, we could have gone down the road and look at the pure legal concept of the right to privacy and the dignity of the body, and the right and the necessity to respect the dignity of the individual and the autonomy of an individual, and more so the extent to which an elderly person can exercise his own consent and exercise his free will in taking this vaccine or not. But in light of the fact that after you administer a vaccine, there are other administrative responsibilities that you must discharge in relation to administering a vaccine. And that is why, Dr. Morgan, I don't want you to go very far because I'm going to need your assistance. We heard Dr. Shearer speak about the convoluted forms that had to be filled out when administering the COVID vaccine. It is my well, before I go there, we now have 1 year, 3 months, and 11 days before all data controllers, which we all are, have to comply with the Data Protection Act. Given the hour, I'm going to skip over this and I'm going to stop here. So the Data Protection Act has specifically identified health professionals. They've identified them as and you are one of the few industries or professionals or entities that have been recognized under the Data Protection Act. The reason why you have been identified and specific and highlighted in the Data Protection Act is because of the nature of personal data that you process. You process sensitive personal data that consists of genetic data, biometric data, one's physical condition, and their mental health. Any of this information can be used in a manner that works against the best interests of your patients. And if this information were to be compromised in any way, it could have significant impact. The Data Protection Act also identifies and points out the information that you specifically process, and it gives it a name. It speaks to health records, any record which is in the custody or control of a health professional in connection with the care of an individual and consists of information relating to clinical information about diagnosis and treatment. So again, it's no longer necessary to focus on the esoteric, pure legal discussion about the right to privacy and the dignity of the human being, because that right to privacy has now been translated into legislation that specifically recognizes the critical role doctors play in our society and the critical nature that you process. And let me take one step back, because a lot of us may be asking, so why this Data Protection Act any at all? And more so, why have we been singled out? Because I think this, well, when I last met with other members of your profession, I may not have really focused on the fact that you were singled out. So let me answer the question why that you may be asking. When the government of Jamaica wanted to collect biometric data and other data about individuals with a view to developing NIDS, the NIDS system, the national ID system. The people of Jamaica said no. The opposition are supposedly, based on the will of the people, went to the Supreme Court and said, you cannot just collect our data like this, and as a matter of fact, make it mandatory and punish us if you do so. Our Chief Justice, as you saw the beginning of the presentation, said, I agree with you. If any government agency, if any individual or any business is going to process anybody's data, you must ensure that there's a robust data protection framework in place. And it is in response to that cry of the people, of which we form a part of, the Data Protection Act was promulgated. So this is something that the people of Jamaica called for, to protect our data against the government. But our Chief Justice said we only need to be worrying about how the government uses your data. Private sector entities also process your data. And there must be a law that governs how everybody processes our personal data, because we have a right to informational privacy. Health records and the medical profession has been singled out because of the nature of personal data that you process, and the fact that any unauthorized or compromising of this information can actually lead to discrimination. And in our Constitution, there is a right against discrimination. And there are several other charter rights that have been guaranteed that it could also negatively impact upon. So let me jump now to this. And Dr. Morgan, this is where I'm going to need your assistance. So what are we supposed to practically do when we're speaking about the administering of a vaccination from the administrative side? How does the Data Protection Act, how does privacy, how does that impact on what we are required to do? And I was invited to speak on the legal implications or the legal issues relating to administering of vaccines for the elderly people. And this is one of the most pressing legal issues that you have to treat with. In conducting or completing the administrative paperwork around administering a vaccine, what are your legal responsibilities around that? So what you ought properly to do, in light of the fact that you're processing sensitive personal data, and which is regarded as a health record under the Data Protection Act, the first thing you need to do is identify what are the risks associated with processing this type of data. You need to do this for all the different data sets that you process and the process within which you process this personal data. But for the purposes of this presentation or this discussion, we're focusing specifically on vaccines, and COVID did introduce this requirement for health professionals to administer vaccines, and not only administer vaccines, but keep records relating to the administration, the administering of these vaccines. So not only are you required to identify the risks associated with how you process that data that you would be collecting, you are also required to determine, okay, well, you need to do a full risk assessment around that exercise, and I'm going to walk you through a brief demonstration of what is contemplated. So this would just start addressing your minds to some of the work that all of us would be required to do in our organization. You are not going to be required to do a data protection impact assessment on every activity you have, but in certain high-risk exercises where you're specifically processing sensitive personal data and sharing this personal data en masse with third parties for different reasons, you do want to consider the risk associated with doing so. And as a matter of fact, the Data Protection Act requires that every year, all data controllers, not only health professionals, but health professionals have been specifically identified, but the Data Protection Act requires that all data controllers file a data protection impact assessment annually. So, Dr. Morgan, I'm going to ask you to assist me in completing a mini data protection impact assessment for the purposes of this presentation. And given the hour, I thought this type of interaction may be more suitable. Is everyone seeing my screen that says identify the need for a DPA?
Cameron, you're administering a test.
No.
An exam in front of 700 people.
This is not a test. This is work everybody has to go back and do in their organization.
See, let's see how it goes.
So I'm giving you some, this is some nice freebies. This is what needs to happen. This is what you would be required to file every year.
All right.
So as it relates to, so in the context of unless use COVID vaccines, after some period of time, doctors were allowed or mandated or co-opted into administering COVID vaccines. The first question that we have to ask ourselves and answer, and I'm going to ask your assistants or anyone else.
Go ahead, let's move right.
Please explain broadly what the exercise aims to achieve and what type of processing it involves. And what we're specifically speaking about, we need to identify and speak to what in administering the COVID vaccine, what sort of records do you have to process? And who do you share that with? Or do you collect any data at all when you administer the COVID vaccine?
I'll share with you. When your patients come for the COVID vaccine, they may be your own personal patients, or they may just be patients who hear that you administer COVID vaccine, and they may just be coming in for that purpose. Now, your regular patients, you have extensive knowledge of their medical background already on file. The ones who come in, you have to take some form of history from them to determine their health status and to determine their comorbidities and to determine their allergic status, to determine whether or not they can actually qualify to take the vaccine. Now, in order to be able to give this vaccine, you also have to have in your medical practice some ways and means of dealing with any allergic responses which may take place, simple problems which may take place. So you have to be prepared, whether you know the patient or not, to deal with some amount of complications that might arise. Basic information would be.
1 second, this exercise would include taking history for okay. So that's a general one. So how will you collect this data from them first? How is this information collected from them?
Well, I try to have forms already pre-done, which picks up general information. The same sort of questions are asked of everyone and they answer it. And it's general information and specific information about vaccines administered in the past, how they reacted to it. And
okay, no problem, that works. The next question is, how do you, well, and you're speaking about best practice. So let this not be a test for you. Let's speak about best practice. What ought to happen. So how is the information that is collected used?
Well,
apart from what you
apart
said,
from using it to make a decision on whether the person is for vaccination or not.
How is it used outside of that specific?
Well, there are forms which the ministry has supplied, which need to be filled out for the Ministry of Health to be returned to them. Or nowadays, this can be done online to a certain extent to be submitted to the Ministry of Health. So there's that part of so they collect back, you fill out the forms that are given you with the information requested of you, which will be returned to the Ministry of Health. Some of that information, basic information, I keep because I need to be able to, if I'm questioned, which I have been in my time, because I do give the vaccine. I've been asked, we've only received on X amount of patients. Did you give more? There was a problem at the ministry with not having logged some of these patients. And so I needed to have backup. It was my responsibility to be able to say that I had given these patients the vaccine, the date, the type of vaccine, when that vaccine was due to expire and when I gave it, the brand of vaccine, the number, each vaccine set has its own specific number. So all of that information, the age of the patient, and also information as to when they had their last vaccine.
So question, so what is best practice in relation to how this data is stored?
Well, this data is, for me, is stored. I have
let's say best practice.
Well, sir, I don't quite sure what you mean best practice. I mean, it's stored, documented on my computer, and for which I have, because of yourself in the past, I have established a firewall, and I have established some other stuff that you spoke about in the past. So you're not gonna catch me there, right? And I'm a proponent. I listen to you, sir. As I told you, I know you're coming. I don't know why the Lord put me here to be with you tonight.
No, man, but remember,
I know this gentleman.
Remember, you're also the moderator, you know, so you could also get other people involved. I just need to have the questions.
Okay,
answered.
well, you know, that's because I don't know if you're going to get hands up here. You know, you're a policeman, so.
Not in this instance. I'm the defense advocate tonight.
Yes. Yes, we're going. You know, does anybody in the audience want to speak to Mr. Cameron's question here as to what is best practice, because if there's a show of hands, then Sam can take a hand. In the meantime, I would say that my best practice has been the storage and filing on the computer, and I do have a hard copy of the basic information required by the government, which they asked me to take before I can give the patient a shot. So this information has already been preordained by the government as standard and acceptable. So and the storage is on computer with proper firewall and notifications, and in a hard file.
So the
which
information
is stored in a safe place.
The information that is received directly.
It's received directly by myself. And the patient is given the
It's received
from the patient. The only person who may be intermediary with that is my nurse. Nobody else handles the information.
Right.
No.
And you said this information will be shared with the government of Jamaica.
As they require their documentation and it is returned to them, I return it personally.
Is it shared with anyone else outside of the Ministry of Health?
I wouldn't know. I return it to the Ministry of Health directly. I don't share it with anyone else. I return the documents, and so this is, remember, we are under oath per se to have a duty to our patients. I do not share any of my patients' visits, recorded documents, whatever document, with anyone else without not only their verbal, but their written consent.
Lovely. So just to step back a little and put what we're doing into context. So while you have that oath that you must take and your code of ethics in general, how you treat and process this personal data, as I said, is now specially recognized by the legislation, and there are specific processing standards. And what this exercise that you are required to file every year treats with is, in order to safeguard the data, do you have an appreciation of the nature of data that you're processing, the risks associated, how you're processing it, and how you protect that? So that is what you are required to demonstrate, and that is the purpose of the data protection impact assessment. So let us continue. So we're going to describe the scope of processing. What is the nature of the data, and does it include sensitive personal data? The answer to that is yes, it does. It does include sensitive personal data, and specifically health records as defined by the Data Protection Act. Well, we already spoke about, well, we don't have to go into how much data is collected and how you'll be using it. How often is this data collected?
In terms of the COVID vaccination, it is collected at the intervals that we're supposed to give the patient the vaccines. So whenever the government says a second dose is due, a booster, first booster, or as it's just occurred since last week, the second booster for the COVID vaccine is due. So we see the patients, either we contact our own personal patients who've given the vaccine, or people come in, and when they come in, I ask for them to bring their prior vaccination cards with them if I haven't seen them before and I haven't got them on file, because if they want a booster, I want to see the vaccination card from before to see what they had, what information is on the card about their status of vaccination. So before I give another one.
So I think you have done, and I'm very grateful, because I did put you on the spot. I did not have a prior conversation with you. So I'm very, very, very grateful for your participation. But I'm going to relieve you and not cause you any more distress at this hour.
Well, I am not distressed, but here I am doing my best.
Thank you very much. So I'm just going to walk you through, and everyone listening, the type of questions that you have to be asking yourself, and this is what you will be required to file at the end of every year. It is somewhat, the government or parliament, when they passed this aspect of the legislation, may not have had a full appreciation of what a data protection impact assessment involves. And the reason why I say so is that one would usually do a data protection impact assessment around a specific type of processing, not necessarily around an organization. But as it is worded very widely. So what we have been doing for our clients is doing a data protection impact assessment on all their processes. But for this exercise, we're just focusing on the process related to administering vaccines. So you then need to be asking yourself, you then need to make a determination as to how long would you keep this information? And this is something the industry needs to sit down and discuss among yourselves with the various associations you have. If you're to look at the NHS, they have very detailed prescribed data retention periods for different categories of health professionals. If you were the doctor if you're a hospital that just saw the person one time, or if you are the physician for the patient, and dependent on the different categories of data you're collecting, there are different data retention periods. But one of the data processing standards is that you can only keep this information, well, you're only allowed to keep it for a finite period. And that finite period must be captured in a policy somewhere. So moving on, describe the context of the processing. What is the nature of your relationship with the individuals? So you'd have started to speak to that earlier, where you said some of them are my existing patients, but because we offer this vaccine, some of these may be persons that may have walked in off the road for the first time. Then how much control will they have over the information that they are processing? And this one is very important, because the relationship you had with your personal notes and your intellectual property that you have recorded on paper when you make your own diagnosis is significantly impacted by this legislation. So prior to now, the common law recognized that when you make your notes, that represents your intellectual property, and the only time you need to share that information is when a patient needs it to be sent to another doctor for the purposes of getting treatment. Outside of that, a patient wouldn't necessarily have a right to access your notes. under the Data Protection Act, it is now his information and he has a right to access information, and you have a duty to provide your entire file to him within 30 days. So that speaks to how much control would they have. So the appropriate response would be that at any moment, well, we have a system in place in which we can ensure that he gets all the information we have generated about him within 30 days. What would they expect to use their data in this way? So would they expect that you are going to be sharing his information with the Ministry of Justice? I mean, with the Ministry of Health. And the answer for the unsuspecting person, the answer to that would be no. So you do have a duty to notify him and let him understand. So the government requires to collect this information from you, and we will be sharing this information with the government. And you need to be in a position to prove that you made him aware of this.
Sir Cameron, we have 3 minutes left.
Lovely. No, but I'm good to hear that. Describe the purposes of processing. What do you want to achieve? And you'd have gone through the fact that you are doing this because the law, one, it is out of a vital interest. You are trying to save lives. And two, you are capturing this information in order to make a proper diagnosis to save lives and prevent the loss of life. And you are sharing it because the government said you must share this information. We don't have to look at the consultation aspect. Then this is in answering this question, this does require the insights of someone who appreciates the whole question of principles deriving from the Constitution that speaks specifically on necessity and proportionality, because you have to be asking yourself the question, how much information are you taking? Is all of this information necessary? Is it proportional to what you're trying to achieve? And in the sharing of the information, you have to address the same type of issues. Then now, when you look at identifying and assessing the risk, where do you share this information? I mean, where do you store this information? How do you collect this information? Do other persons hear when you're collecting this information? Is there any danger in how you share this information with the government? And then you actually have to wait and make a determination as to what is likely to happen, what the extent of harm that may flow from the activity, and then the overall risk. And then finally, you really need to identify the measures that you have taken to reduce the risks that you have identified. I hope that this has been beneficial, the manner that I went about making this presentation, to make it very practical, because you have heard about the Data Protection Act. Persons like me may have made presentations before that may have caused you some consternation. So I just wanted to share a very practical example in the context of administering vaccine, that some of what your responsibilities are. So thank you very much for the opportunity to share. And I hope you have left here this evening with some new information. Thank you very much.
Well, thank you to Mr. Cameron on this whole vital role of the right to privacy, the right to informational privacy, and looking at the unauthorized use of personal information leading to infringement of our rights, and how sometimes we do this without, we do this without knowing that we're doing this. In the little things that we do, in who sees the documents, and how is information move forward to other entities, etc. So even in how we administer vaccines, we are seeing there are many responsibilities along the pathway. So it's serious business. As Mr. Cameron told us, we have, what was it, 1 year and how many days and months, I forget, before we will have 1 year, 3 months and 11 days before we have to comply with the Data Registration Act. And I think that that is his message, that this thing is coming for all of us, and we need to be very aware that it's serious business. He hasn't told you anything about the horrible, horrible fees. Leave that for another time. Okay, sir, so we move on, and thank you. We move on because we still have one person who is waiting patiently for his turn to speak with us. And that is Dr. Peter Glegg, who is both a general surgeon and an attorney at law. And he has, Dr. Glegg, we thank you so much. I have heard from you personally. I'm sure everybody here has, many, many times in many different forums, often with MAGIF. I asked you to talk about legal matters also with the young doctors in their stuff. Always wanted to know about legal matters to do with the surgeries and so. So we want to apologize for the lateness that we've kept you here, but we know you always have something worthwhile to say. So let me quickly introduce you as no stranger. He's the senior legal advisor for the University Hospital of the West Indies. And as an attorney at law, he represents the interests of the hospital in the Emergency Operations Committee for the Ministry of Health and Wellness. And he also has a lot of experience with dealing with COVID-19 issues and how they pertain to the pandemic and the various laws in Jamaica. And he is a member of the University Hospital of the West Indies COVID-19 Task Force. So he deals with the COVID-19 pandemic and its legal matters, and he has a lot to share with us. He is also a lecturer at the Norman Manley Law School at the Mona campus. And he has quite a background in television, yes, student affairs and teaching. So, and he is, let me tell you, he's a senior resident in general surgery at the St. Anne's Bay Regional Hospital. So I'm just going to ask you, Dr. Glegg, we note, following up on Mr. Cameron, we note that you are considered to be a global expert in the field of telehealth law. So moving forward, and we're asking you now to take the stage, and let's hear your presentation tonight on the whole issue of ethical issues in vaccinating the elderly. Over to you, Sir Glegg.
Thank you so much, Dr. Morgan, and thank you for inviting me to join you this evening. The night is well spent, and I promise you my presentation will be very, very, very short. Want to quickly take a look. Just please advise me if you are able to see my screen. All right, so okay, so let me just move ahead very quickly. Let me go to.
We're not seeing it yet, Doc.
All right.
Yeah, there you go.
Okay, all right. I'm not seeing it now, but I guess it'll come up eventually for me. All right, so my duty tonight is to talk about the ethical aspects of vaccination in the elderly. And I want to start off by giving 2 quick scenarios. Can you see my screen? Can you see the change in my screen?
Yes, I'm not seeing a change, but I'm seeing your screen.
Okay, I'll resume slideshow. Okay, I'm not quite sure what's going on here. Well, all right.
All right, I started it over for you. Let's try again.
Okay. Let me share my screen. I'm not seeing anything now. Wow. Stop share. All right. Oh, I lost my PowerPoint. Hold on one moment.
No problem. Take your time.
Let's see. I think. Wow. All right. If I don't find it back in a minute, I will just do it without the. I'm not sure where it went. All right. Okay. In the interest of time, I'm not quite sure where my PowerPoint vanished to. I will just have a straightforward discussion. All right, so I'm going to give you two scenarios instead of wasting your time trying to find out my PowerPoint. So the first scenario that I prepared for you was a 72-year-old Rastafarian lady who in her early days was known to be a conspiracy theorist and who was forced by the authorities to vaccinate her children. She's now in her 70s. She has severe dementia. She doesn't know anything, doesn't recognize her kids, and her now grown scientific-minded kids are desirous of taking her to get the COVID-19 vaccine. How do we treat with a situation like that, knowing that she is against vaccinations, but now she's elderly and her kids want to take her for a vaccine? The other scenario that I want to bring forward to you is the issue of an elderly, a young lady, I call her Miss Gucci. She loves to shop, and she has two elderly parents who she takes care of. The Ministry of Health has said that they are giving a $10,000 incentive to any person over the age of 60 who is fully vaccinated. And she's determined to get both her parents fully vaccinated because she needs that $20,000. The other issues in terms of ethical issues that you face when it comes to vaccination in the elderly, and I'm going to play devil's advocate tonight. The first one is, if you notice in the early days of the vaccination, the government gave special priority to the elderly. I think they started with the age group over 75, and of course, healthcare workers and police, military, and so on. And then I think they went down to 65 and then down to the age of 60. So here's my ethical question, and I'm just playing devil's advocate because I've been asked, because at the time, young people were not able to get the vaccine. And someone came to me to say, how is it? Is it legal for a person over the age of 65 to be offered the vaccine, and yet still I am 25 years old and I can't get the vaccine? What about equality under the law? Is it fair for an elderly person to access the vaccine when I, as a younger person, had access to vaccine? So that is also a major issue. And of course, my learned counsel who presented before me alluded to the issue of consent as it relates to the issue of vaccination in the elderly. Now, one of the things I want to bring your attention to is the Constitution, which represents the highest law in Jamaica. Section 13 of the Constitution, which is the Charter of Fundamental Rights and Freedoms, speaks to the fact that persons have a right, of course, right to freedom of movement, right to denigrating treatment, right not to be tortured, and so on. But while the Constitution gives these rights in one hand, on the other hand, it takes back these rights to say that though a person has these rights, the government has the power to restrict an individual's freedom, to prevent the spread of a contagious disease. So what we're seeing in the spirit of the Constitution is that the law puts the general interest of the public before the interest of an individual. Now, of course, the Public Health Act also gives the minister the power. I think it's Section 6 of the Public Health Act actually gives the minister the power to mandate a vaccine. We know that there's a vaccine mandate that all children below a certain age have to get vaccination in order to enter school, and this is a statutory requirement. The government of Jamaica, and I pulled this information off the internet, they decided that they would not use the draconian route of forcing everyone to take a vaccination. And the approach that the government took is actually they sent out a consultancy to say that they wanted a consultant to assist the government in developing some sort of vaccination policy as it relates to adult patients. And they also recognized in this document the fact that though we have a pandemic now, there may also be pandemics in the future as well. So the first question I want to ask is, what do we do about Mildred, the elderly Rastafarian, who we know is against vaccine, but now she's senile, she's demented, she's in her 70s. Can we take her to get vaccination? Who speaks for the elderly patient who cannot speak for themselves? Or is it a situation whereby we have to look at the best interest of the patient, right? As compared to maybe what the patient may have thought prior to her losing her ability to give consent. All right, so this is something that we have to bear in mind, because when we talk about ethical issues are a little different from legal issues. Ethical issues is when you face a dilemma. And how do we deal with a dilemma in this situation? How do we deal with the dilemma of someone bringing their parents to get fully vaccinated, not because they care about their health, but because they want that $10,000 that the government of Jamaica had been offering during the height of the pandemic in order to encourage elderly patients to get vaccinated. The other ethical dilemma that we can touch on is the issue of why is it that some persons are given priority over others? If we are a free and fair economy, why is it then that an elderly person should be offered the vaccine when a young person is not? And I think Dr. Shearer answered the question in her presentation in the fact that the elderly patients were most at risk as it relates to the potential of serious outcome, whether morbidity or mortality from contracting the COVID-19 virus. So the reality of our legislation is that we look at the greater good instead of the individual good. Now, the final issue I want to raise, the other dilemma that I want to raise, and the other ethical issue, the reality is at the time the vaccine was rolled out, there were some studies and there was some evidence to prove that the vaccination was valid. The fact is that the companies that produce the vaccines were indemnified against lawsuits. So if you had a negative outcome with a vaccination, such as a serious allergic reaction, for instance, you could not bring a lawsuit against the company that manufactured the vaccination. And also the fact that the WHO and the CDC and other agencies had to make a decision to say, we are looking at a risk versus benefit analysis. What is the benefit of giving a vaccine that we have significant data, though the duration of testing was very short? Because you must remember in the past, vaccines took 10 years to develop. While with this, because of the risk and the dangers associated with COVID-19, and I saw this with my own two eyes, the reality is that we had to use that technology and we had to administer that vaccine. So this was a dilemma that was faced by the WHO and something that we have to ask the ethical question. as physicians is, you know, this thing was only developed in a year or two. Can we give our grandparents or parents this vaccine and we don't have the data? Now, in retrospect, we do have the data, but these are some of the ethical issues that physicians have to deal with as regards to the vaccination of their elderly relatives. And of course, what do we do when the next pandemic comes? So I'm playing devil's advocate today, and I would love to hear if you think that there should be equal rights and justice. And when the vaccination was rolled out, everyone should have been given access and not the elderly patients given special access. With that, Dr. Morgan, I end my presentation here. I'm sure I've ruffled a lot of feathers, and it should be interesting to hear some of the questions or comments. Thank you.
Okay, thank you very much, Dr. Glegg. And we want to see if there are any hands quickly, because we don't have a lot of time, but we want to see for a little bit of interaction. Dr. Glegg has asked for a little interaction here.
All right, guys, if you raise your hands, I'll allow you to talk. I see Patricia Bailey. Dr. Bailey, your microphone's available. If you go ahead and unmute, you could speak to Dr. Glegg. Anybody else who would like to speak, please go ahead and raise your hands outside of that. Dr. Bailey, was it a mistake? You can go ahead and speak right now. There you go. All right, you're muted again. Unmute. Patricia Bailey, there you go. Hi.
Hi, doctor.
Hi, good afternoon.
Good afternoon. I just want to say your presentation was very good.
Okay, thank you very much.
Well, I guess I'll say something, Dr. Glegg. My thoughts are that we have to go with the science here. And just as same thing Dr. Eldemire, Professor Eldemire spoke to, is that we know, you know, when we had the vaccines, first it was for the 75-year-old, and then it was for lower age plus people with chronic diseases. It's when you have a limited amount of vaccine, as we had at the time when this vaccination process first started, you have to deal with your most at-risk set of people. Remember, to this day, below age 50, it's 1% of people who die. If you're up at age 90, it's 14–15% of people who die when they get the COVID-19 infection. So these figures speak, and they're important. And as you say, we have to go with that. You know, and as more and more vaccine becomes available, you open it in a ring fashion downwards, because that speaks to the outcomes. You know, so we have to do it as we have the medicine available and according to the outcomes, and make it available. I wish now that we have enough vaccine, or have been having enough vaccine for everyone, that we could do something to make those people who were quarreling before go and get the vaccine. So those are my thoughts, Dr. Glegg.
I thank you so much.
The interaction, yes.
Well, that's it for me for tonight.
That's it. Okay, well, all right. Well, let me take this opportunity, Dr. Glegg, to thank you for, let me call it short and sweet, because it's exposed us to some of the dilemmas associated with the whole idea of COVID vaccination, and some of the issues that concern people who sometimes it's not the vaccine itself, but it's the idea of their rights. It's my right. And so sometimes whether or not they're interested, really, it's because of their right. And this is real, and I suppose we'll have this debate again going forward. Into the other query we have monkeypox now. Well, I doubt this will ever be similar to the COVID, but you know, and we will expect others. So Dr. Peter Glegg, thank you again for sharing with us tonight. Your time here has been appreciated. And it is now for me to just hand over to another colleague of ours. Q&A. I don't know if we have, what you say? Did we have any?
No, we have to skip the Q&A. We'll go straight to Dr. Campbell.
Mr. Cameron. So moving on to Dr. Monique Campbell, who is again someone that I personally know. And hello, Monique. She is a member of the CCFP, and she is here tonight to give the vote of thanks. So Dr. Monique Campbell, over to you.
Thank you very much. Good night, everyone. It is indeed a pleasure for me. It is indeed an honor for me to move the vote of thanks tonight. I would first like to thank the CCFP for hosting this well-needed event. The elderly is a neglected group along the life course, but with the current demographic transition with aging in the Caribbean and the world at large, this discourse was a well-needed one for the proposed interventions concerning the needs of this group, immunization, nutrition, and ethics concerning the elderly. I would like to thank our speakers for very impactful, practical, and insightful presentations. Dr. Naranjo, for the significance of her presentations, especially on, I really got home the points about boosters, especially for pertussis in the elderly. Dr. Callender for nutrition in the elderly. Professor Eldemire-Shearer for her presentation on medical issues in vaccinating the elderly, and really how we can decrease the aging divide between the elderly and our younger population. Mr. Cameron, attorney at law, for his highlights, his very practical highlights on legal issues concerning the elderly. And lastly, our speaker, Dr. Peter Glegg, who is an attorney at law and also general surgeon, for presenting on the ethical dilemma concerning immunization in the elderly. I would really also like to thank our organizers, our CCFP president of the Jamaica chapter, Dr. Onanuju, administration, Mrs. Hyatt, our IT and technical support team from the CCFP, and also our moderator and colleague, Dr. Brown Morgan. I'd also like to thank our sponsors, GSK and INDUS Pharma, and our attendees and members of CCFP for attending and being here, and also being very interactive in this presentation. So thank you all for a very wonderful and but well-needed CCFP, another well-needed CCFP event.
Thank you very much, Dr. Campbell. And we also thank Dr. Onanuju and Dr. Arlene Henry Dawkins for their input tonight. Thank you, audience. There were nearly, I think, 780 of us at one point. We're at 537. We have endured, but we have also experienced a wonderful night. So we just want to say thank you. And again, thank you to Dr. Monique Campbell for bringing us our evening to a close. I just thank you, everyone. And good night. Good night from the CCFP Jamaica chapter. You can expect to get a mail out of your CMEs. Don't have to worry, it will go to you.